All right, welcome. Today we're doing a clinical masterclass on a fascinating organism, Trichomonas vaginalis. Now, this is a parasite that, for how incredibly common it is, really does seem to fly under the radar.
And I'm not exaggerating its prevalence. Just think about this for a second. Trichomoniasis is the single most common non-viral sexually transmitted infection on the entire planet. So you can see why understanding this organism isn't just an academic exercise, it's absolutely vital for clinical practice.
So, here's our game plan. We'll start with the parasite itself, then move into diagnosis, treatment, and containment. After that, we'll cover the long-term risks, and then we'll wrap up by putting it all together with a few clinical cases.
Okay, Section 1. Let's get to know this elusive parasite and the disease it causes.
First things first, it is critical to remember that T. vaginalis is a protozoan parasite. It's a single-celled organism with a flagellum, that little tail that helps it swim around. It is not a bacterium, and that distinction is going to be huge when we talk about treatment. And, fun fact, humans are its only natural home.
Now let's look at the timeline. After exposure, the incubation period is usually somewhere between 5 and 28 days. The parasite itself is actually quite fragile. It can't survive for more than about 3 hours outside of a host. But here's the most clinically significant part. The infection can hang around for months, sometimes even years, all while being infectious, even if the person has no symptom.
And this is where it gets really tricky from a clinical standpoint. The presentation is highly variable. I mean, up to 90% of men who are infected might show zero symptoms. None. For women who are symptomatic, you might see that classic presentation. You know, the foul-smelling, yellow-green, sometimes frothy discharge. And while it's a textbook sign, that distinctive strawberry cervix you might see on a speculum exam, it's actually not all that common.
So, it seems this parasite, though microscopic, has a rather large and dangerous social circle. By changing the vaginal microbiome and raising the pH, it doesn't just hang out with bacterial vaginosis, it actually seems to make people more susceptible to both HIV and HPV. That's a huge deal.
So with all that variability, how do we actually find this thing? Let's move on to Section 2, diagnosis. For years, the go-to was looking at a wet mount under the microscope, trying to spot these motile little guys swimming around. And while that can work, its sensitivity is frankly pretty low. The undisputed gold standard today is the Nucleic Acid Amplification Test, or NAAT. It is just far superior in both sensitivity and specificity, which really makes it the only definitive diagnostic tool we should be relying on.
Right. So once you've got that confirmed diagnosis, it's time for treatment. Let's dig into the standard protocol.
The drug class of choice here is the nitroimidazoles, and specifically oral metronidazole. As a clinician, you've got two equivalent first-line choices. You can go with a single high dose of 2,000 milligrams, which is nice because it often takes care of coexisting bacterial vaginosis at the same time, or you can opt for a 7-day course of 500 milligrams twice a day. Now, the patient counseling here is absolutely non-negotiable. They need to abstain from sex for a full week after finishing treatment. And this is the big one. They must avoid all alcohol during treatment and for 48 hours afterward. This can cause a really severe disulfiram-like reaction. Think violent nausea and vomiting. It's also important to tell them that any kind of intravaginal cream or gel is much less effective and definitely not a first-line choice.
But treating the patient in front of you is really only half the battle. If we want to control this infection, we have to think bigger in terms of public health and containment.
Partner notification is essential to stop the cycle of reinfection, with the patient's consent, of course. All sexual partners from the last month or so need to be informed. Now, here's the key takeaway, the most important part of this protocol. Partners have to be tested before they're treated. Just blindly treating them without a diagnosis is a bad practice that can fuel antimicrobial resistance.
Because if trichomoniasis is left untreated, it is far from a harmless infection. The long-term consequences can actually be pretty severe.
And these risks look different depending on the population. For women, an untreated infection can travel up the reproductive tract and cause pelvic inflammatory disease, or PID, which can lead to infertility or preterm birth. For men, it's linked to things like prostatitis and an increased risk of prostate cancer. And for newborns who are exposed during birth, we can see infections and low birth weight.
Okay, section 6. Let's see how this all plays out in the real world. Time to put theory into practice.
All right, case number 1. A 28-year-old female comes in with that classic yellow-green frothy discharge, and her vaginal pH is up at 6.0. What's the best test you can order? The most sensitive and specific one.
The correct answer here is B, a vaginal NAAT for Trichomonas vaginalis.
And here's why. As we discussed, NAAT just blows everything else out of the water in terms of sensitivity and specificity. Sure, you might see it on microscopy, but you can't rely on that to rule out an infection. NAAT is the gold standard, plain and simple.
Okay, case number 2. You have a 35-year-old man with a confirmed case of uncomplicated Trichomonas urethritis. What's the recommended first-line oral treatment?
The correct answer is C, metronidazole, 500 milligrams orally twice a day for 7 days.
And this is such a critical point to remember. Common STI drugs like doxycycline, azithromycin, or ceftriaxone, they're for bacteria like chlamydia and gonorrhea. They do absolutely nothing against this protozoan parasite. For T. vaginalis, you have to use a nitroimidazole, like metronidazole.
All right, our final case. What is a known major complication for a woman who has an untreated Trichomonas infection?
And the answer is C, pelvic inflammatory disease, or PID. This just brings home that earlier point about complications. For women, the big fear is the infection ascending and causing PID, with all the reproductive issues that follow. For men, the concern is more around prostate inflammation and that potential link to cancer.
Which leaves us with a final, pretty provocative question. We know there are millions of asymptomatic carriers out there who are not only suffering potential long-term harm, but are also continuing to transmit the infection. So, is it time we rethink our screening protocols? Is our current approach, which is mostly based on symptoms, really good enough? It's a major public health challenge worth thinking about. Thank you for joining this explainer.